Our next section is various movement disorders, amyotrophic lateral sclerosis or Lou Gehrig's disease, Charcot-Marie-Tooth disease, peripheral neuropathies, facial nerve palsy, also known as a Bell's palsy, and Guillain-Barré, which is sometimes called acute inflammatory polyneuropathy, and myasthenia gravis. ALS is exclusively a loss of motor neurons. Now, it may be both upper and lower motor neurons, but it's only motor. There is no sensory loss. The sphincters are spared. But it's not just the sensory and the sphincters that are spared. It's cognitive defects are spared, and sexual defects are spared, and, well, everything is spared. It's only motor disease. It is idiopathic, and it is very frustrating because we have nothing to reverse it. Since there is no specific diagnostic test for ALS, the most likely diagnosis question is a symptom complex. You will answer ALS as the most likely diagnosis when you look for weakness, motor weakness, starting in the 20s to 40s age, and a combination of upper and motor lower neuron loss with an initial presentation that tends to be a bit more descending, chewing and swallowing, and disordered swallowing. When a patient has a decreased gag reflex, this results in a person whose pooling of saliva in the pharynx and weak cough leads to frequent episodes of aspiration. Because normally we make 1 to 2 liters a day of saliva, and you take it for granted because you just swallow that. Wow, did you know that you make more saliva each day than urine? Well, where does it go? Well, I swallow it and you don't even notice it. But if you have ALS and you have disordered swallowing, ooh, it's going to go into your lung. And that is why death can occur in patients within 3 to 5 years because they continue to have recurrent pneumonia and aspiration, lung abscesses, and respiratory failure. The survival in ALS is exclusively dependent upon how clean, how accurate, and how tidy. The phrase pulmonary toilet would not be inappropriate. That's an accurate phrase. How clean do you keep your lungs? You keep your lungs clean, you'll live. Since there is no diagnostic test for ALS, the diagnostic test is really a definition of symptom complex. And that symptom complex is the combination of upper motor neuron defects such as weakness, simple weakness. Spasticity happens only with upper motor neurons. Spasticity only in the upper. Now, upper motor neuron gives you weakness, but you don't actually have wasting. The muscle actually doesn't dissolve because it's hyper-stimulated in a way from an overactive reflex arc. Whereas lower motor neuron defects is like the puppet strings being cut. It just wastes away. It's like a cut flower. Upper motor neuron defect gives you hyperreflexia, whereas lower motor neuron defect, for unclear reasons, there's fasciculations, a rapid, tremulous state of muscles that nobody understands. And upper motor neuron defects is upgoing toes, extensor plantar reflexes.
Okay, can you go back and forth? There you go.
Although electromyography is certainly abnormal in ALS and there'll be loss of neural innervation in multiple muscle groups, I mean, after all, that is how you get the wasting and the weakness. This is not the same thing as saying that this is a specific diagnostic test, but you do see high CPK levels because the muscles become atrophic, and as they atrophy, they die and release CPK. Riluzole is a medication to help reduce glutamate buildup in the neurons. Now, this doesn't cure the disease, it just delays the progression of the disease. Baclofen is used, as it is in multiple sclerosis, to decrease spasticity, as you can also use tizanidine. CPAP and BiPAP, positive airway pressure, a mask on the face to blow the uvula out of the way, is far more important because these modalities help respiratory difficulties secondary to the muscle weakness. The major problem in ALS is that you can't take a good deep breath, you can't cough. This means that you need extra help in your inhalation. That's what CPAP and BiPAP do. Daytime somnolence, sleepy during the day, don't intubate. CPAP. Now, when all the other modalities fail, tracheostomy and putting a cuffed tracheostomy tube in to maintain people on a ventilator, such as at night. Instead of aspirating, go on a ventilator at night. And maintenance on a ventilator is necessary when the disease advances, and the cuffed trach and positive pressure airway ventilation helps protect you from having aspiration pneumonia, particularly when you can't cough it up at night. Charcot-Marie-Tooth is an uncommon genetic disorder where you lose both motor and sensory. ALS is just motor. This is motor and sensory innervation, leading to distal weakness and sensory loss, wasting in the legs in particular, decreased deep tendon reflexes, and a tremor. Now we have two relatively unique physical findings here that are indispensable for you to learn. After all, they are pes cavus, a high arched foot deformity, and legs that look like inverted champagne bottles. That's the term. I don't make this stuff up. Champagne bottle legs and Charcot-Marie-Tooth syndrome. And the most accurate test is electromyography, showing decreased innervation, and there is no treatment for this disorder. This is a very small knowledge base on Charcot-Marie-Tooth. Basically, you know the champagne bottle legs and the pes cavus, and you are done. The opposite of Charcot-Marie-Tooth in frequency is the peripheral neuropathy of diabetes mellitus, which is the most common cause of peripheral neuropathy by far. Glove and stocking distribution, small neurons, diabetes mellitus. Now, uremia, renal insufficiency, also causes neurologic dysfunction. Alcohol is a direct toxin to nerves, and paraproteinemia is for unclear reasons. Monoclonal gammopathy of unknown significance, MGUS, is associated with a peripheral neuropathy. Nobody knows why this happens, but in a disorder that is generally asymptomatic in the majority of patients. The most common symptom when it does occur of MGUS is actually peripheral neuropathy. The initial therapy for peripheral neuropathy, regardless of the cause, is pregabalin or gabapentin. And although tricyclic antidepressants such as amitriptyline can be used, these medications have less adverse effects. They can cause some sedation, pregabalin, gabapentin, but they don't cause the dry mouth you get with tricyclics. Tricyclics cause dry mouth, urinary retention, constipation. Dry mouth, urinary retention, constipation. Pregabalin and gabapentin don't do that. You will not be asked to choose between these three drugs. They're not going to say which of the following is the most effective drug and ask you to choose between three drugs that are interchangeable. If these drugs are in the same question, it means they're asking about adverse effects, because that's the only thing that's truly different. Now, no matter the etiology, it's always control the etiology and use pregabalin, gabapentin, tricyclics. Seizure medications are effective in some people, most of them, and phenytoin or carbamazepine, lamotrigine, well, all of these could be used, so can valproic acid, in the same way as we talked about in the headache section. So in the headache section, these are for neuropathic pain and for peripheral neuropathy as well. Specific peripheral neuropathy, such as the ulnar nerve, can be precipitated by, well, when you ride a bicycle and you're leaning forward on the palms of your hands. It causes a vibratory damage to the ulnar nerve that can cause numbness and tingling of the side of your hands, where the ring and the pinky finger are, wasting of the hypothenar eminence. Thenar eminence is with your thumb. Thenar, thumb. Hypothenar is the other side from your thumb. The radial nerve travels underneath your humerus. So that's why it is that if you have pressure on the inner or upper part of the arm, like in crutches or Saturday night palsy is when you fall asleep with your arm over the back of a chair, that's exactly where the radial nerve travels. And that's why the radial nerve will result also in wrist drop, radial wrist drop. The lateral cutaneous nerve of the thigh is stretched when people have pregnant women, obese people, pregnant, particularly with sitting with crossed legs, it stretches it even more and causes pain and numbness on the outer aspect of the thigh by stretching it. It's also L2. Sometimes asked, they say, what nerve root is lateral cutaneous nerve of the thigh? And go think of it like this. Lateral, lateral, L2 for lateral. The tibial nerve is in the foot. It gets worse with walking. It results in pain and soreness of the ankle and sole of the foot. It's kind of like carpal tunnel syndrome, but of the foot. Carpal tunnel, that median nerve gets overused and causes numbness and tingling in your hand with the thumb and the first three fingers. This is the same thing, just in your foot. The peroneal nerve is rather like the radial nerve of your leg. High boots hit under the back of your knee, and the pressure on the back of your knee results in foot drop. Weak foot with decreased dorsiflexion. Dorsiflexion is like saying pull your toes towards your nose. Pull your toes backwards and up towards your nose. And that's what gets weak with a peroneal, foot drop. Radial wrist drop, peroneal, foot drop. The median nerve is our good old friend, carpal tunnel syndrome, typists, carpenters, those working with their hands. Is there somebody not working with their hands? But working with their hands a lot. And the thenar evidence, remember, thenar means thumb. First three fingers, the thumb, the index, and the middle finger become numb, pain, burning, and wasting, particularly with use. The seventh cranial nerve palsy, or Bell's palsy, is almost always idiopathic. There are a couple of identifiable causes, and some of those identifiable causes, Lyme disease can cause bilateral too, sarcoidosis can cause bilateral too, and zoster, and sometimes some tumors that go and press on the seventh cranial nerve as it's coming out of the canal. But most are idiopathic. Now, you have to also look for this phrase that says the face feels stiff or the face feels like it's been pulled to one side. Because remember, sensation is intact. Sensation in the face is controlled by the fifth cranial nerve, the trigeminal. So when you have abnormal muscles of the face, you can feel it with the intact trigeminal. But we have to answer the question, what's the most likely diagnosis? So seventh cranial nerve palsy is paralysis of the entire side of the face, including the eyebrow and the forehead. And that's how you distinguish it from a stroke. The stroke paralyzes only the lower half of the face. The upper part, the forehead, has bilateral innervation. Stroke is only the lower. Seventh cranial is the whole half the face. And the upper half of the face is innervated from both cerebral hemispheres. That's why you can't stroke out the upper half of the face. But you do have in Bell's palsy or seventh cranial nerve palsy a tremendous difficulty closing the eye. The orbicularis oculi muscle, orbicularis oculi, is innervated by the seventh cranial nerve. And when that's damaged, you lose the ability to wrinkle your forehead and close the eye. And that's why it says if they cannot wrinkle the forehead, can't lift it up, can't lift up your eyebrows, it's Bell's palsy, a seventh cranial nerve palsy. Hyperacusis means you hear things extra loud. And the seventh cranial nerve supplies the stapedius muscle. Now, there's two muscles in the middle ear that act as shock absorbers on the ossicles of the middle ear. The incus malleus and stapes. It's like saying the hammer and the anvil. That's what that means. The malleus, like a mallet. And the stape is a stirrup. Well, in that hammer, anvil, and stirrup, the sounds hit it and create vibrations. And one of the reasons that gunshots and sudden sounds can really deafen you is that they don't allow time for the stapedius under the seventh cranial nerve to tighten it up and act as a shock absorber. Damages your ears. Now, the taste disturbance is because the seventh cranial nerve supplies taste, but only to the anterior two-thirds of the tongue. The facial nerve supplies the sweet sensation of taste. The bitter taste is in the posterior third of the tongue. The posterior third of the tongue is bitter taste, and the posterior third is controlled by the same nerves that control the gag reflex, and the gag reflex is controlled by cranial nerves 9 and 10. gag, 9 and 10. Posterior, anterior, 7th cranial nerve, anterior 2/3. Now, I saw a case of Bell's palsy just 2 weeks ago, and I didn't do any test because it's obvious. But I could have said, well, the most accurate is electromyography and nerve conduction studies. No test is usually done, so you've got to distinguish between the phrase, what is the most accurate, and what would I do? What would I do? I'd give them some steroids and send them home. What is the most accurate? Electromyography, nerve conduction. The best initial therapy of 7th cranial nerve palsy is under the presumed mechanism that swelling of the 7th cranial nerve as it proceeds through a narrow bony canal in the face can be improved with prednisone as a steroid. But 60% would have full recovery even without treatment. But you will use it in everybody because it's short-term steroids, and a week or two of steroids never hurt anybody. You don't reactivate your tuberculosis in 2 weeks of steroids. In the past, there was a consideration about using acyclovir, valacyclovir, or famciclovir to treat herpes as well. If it is in your answer choice, the answer is no. This has now been disproven. However, if you're looking at some other sources or question bank questions from various sources, it may say it. That's an indication to you that that question is left over from the past. No acyclovir on a routine basis. A 38-year-old man with pain near his ear, followed by weakness of one side of his face. Both upper and lower parts of the face are weak. Both of them. Sensation is intact. What's the most common complication of this? The most common complication of this person has a facial nerve palsy. A facial nerve palsy is both upper and lower, and the most common complication is a corneal ulceration. That's because you can't close your eyes. You can't close that eye, so the eye gets dry and it ulcerates, particularly at night. Patch and lubricate at night. Patch and lubricate at night so you don't get an ulceration. Aspiration pneumonia doesn't happen because it's the 9th and 10th cranial nerve that control gag and cough up there, that control the sensation of gag that leads to the cough. Sinusitis causes nasal discharge and face pain. Doesn't have anything to do with weakness. Otitis media is ear pain, decreased hearing, but it doesn't have anything to do with facial weakness and deafness. It's the other way around. The sounds are heard extra loud because you lose stapedius innervation. And dental caries don't have anything to do with it because you're not paralyzing a face does not involve your salivary glands. Guillain-Barré is acute inflammatory polyneuropathy. And there's autoimmune damage of multiple peripheral nerves. There is, by definition of the disorder, no CNS involvement. Guillain-Barré is 100% peripheral nervous system. We think the mechanism is that there's circulating antibodies resulting in attacks on the myelin sheaths of the peripheral nerves, and it's associated with Campylobacter jejuni. Remember, association does not mean that it caused it. It doesn't mean it caused it. It means that people with Campylobacter have an increased frequency of Guillain-Barré. We don't know that it actually caused it. That's a different thing. We just know it's associated. In one sentence, Guillain-Barré is diagnosed by ascending weakness and a loss of reflexes. Ascending means it starts out in the feet and moves upwards into the legs and into the abdomen. Ascending weakness and a loss of reflex is Guillain-Barré and nothing else. So the answer to the question, what's the most likely diagnosis, is a matter of looking for weakness of both legs. Remember, it's bilateral. It ascends from the feet and goes towards the chest, and on the way up there, you lose your reflexes. So that'll say areflexia. Areflexia. No ankle jerks, no knee jerks. Start with ankles. Goes up to knees. Ankles are lost first. Now, some people might have some mild sensory disturbance, but the big issue is ding, 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 respiratory muscle weakness. As you go up from the toes to the nose, Guillain-Barré hits the diaphragm. It's going to zap your diaphragm and it's going to kill you. Autonomic dysfunction is much less common, 10 to 20%. Big drops in blood pressure, then up to hypertension, then down to low blood pressure. Up and down. Autonomic instability and dysfunction with tachycardia are definitely part of it. The CSF in Guillain-Barré will show an increased protein with a normal cell count. Now, that's not the most specific test. The most specific test is nerve conduction velocities, electromyography, where you'll see a decrease in the propagation of electrical impulses along the nerves. That's the most specific test. That's why in Guillain-Barré you'll frequently see intense descriptions and questioning about respiratory muscle involvement because the inspiration is the active part of breathing and the patient loses the strength to inhale. As you go from your toes up to your nose, as you ascend up, you can hit your diaphragm and you will see a decrease in forced vital capacity and a decrease in the peak inspiratory pressure because inspiration is the part that's the active part of your breathing. And pulmonary function tests tell who might die. PFTs tell who's going to die. And that's why it really depends on Guillain-Barré. Are they asking you most accurate? Well, that's a nerve conduction velocity. Or are they asking you what's the most important thing to do first? A person's in the emergency room. The most important thing to do first is make sure he's not going to die from ventilatory failure, respiratory failure. Death from Guillain-Barré, although it's rare, can be from dysautonomia and especially respiratory failure. That's why kids with polio in the 1940s and 50s ended up on the iron lung. Because before the eradication of polio, it functioned in much the same way as Guillain-Barré. Ascending weakness, loss of reflexes, and watch out for the diaphragm involvement. Treatment for Guillain-Barré is straightforward. Intravenous immunoglobulins or plasmapheresis are equal in efficacy. But if they're both in the choice, you're going to choose intravenous immunoglobulins. IVIG is simply much easier to give. It's a bag of liquid like giving an antibiotic. You hang the bag, it's in, you're done. Plasmapheresis is very similar to doing dialysis. You got to hook them up to a machine, put a big catheter in a big central line, and take out all their plasma and blood and exchange it. And that is really much more difficult. So IVIG is generally first, even though they're both equal in efficacy. The number one wrong answer is saying to use prednisone. Prednisone is a wrong answer for Guillain-Barré. It simply doesn't help. Combining IVIG and plasmapheresis doesn't help. If you gave intravenous immunoglobulins and you did plasmapheresis, it would remove the intravenous immunoglobulins you just gave. And prednisone and steroids are very easy to make wrong answer. After all, it is an autoimmune event. It is antibodies attacking your peripheral nerve. So if I didn't know better, I would say prednisone as well. After all, it's autoimmune. Let's stop it. Nice idea. It just doesn't help. Just say no to steroids in Guillain-Barré. A woman comes with bilateral leg weakness over the last few days. She's lost her reflexes in the legs. The weakness starts in the feet, goes up to the calves, up to the thighs. What's the most urgent thing to do? The most urgent thing to do is, well, pulmonary function tests make sure that you understand that Guillain-Barré will hit that diaphragm and kill you. And you want to know before they have respiratory failure. If you wait for an increase in CO2 on ABG because of ventilatory distress, they're about to die. Too late. Nerve conduction studies may be the most accurate test, but they're not the first thing to do. You put a needle in their nerve and send an electrical impulse, look for decreased F-wave propagation. Maybe the most accurate, but certainly not as important as knowing whether this lady is going to go to the ICU. Lumbar puncture is okay. It shows a high protein, but it's neither the most urgent test nor is it the most accurate. Peak flow meter is for asthma. Peak flow measures the exhale, expiratory flow. Guillain-Barré is a problem with inhalation, not exhalation, because exhalation is mostly passive. Myasthenia gravis is muscular weakness from antibodies against the acetylcholine receptors at the neuromuscular junction. Now, severe myasthenia can also affect the respiratory muscles, and that's important to know when to answer intravenous immunoglobulin and plasmapheresis acutely. Answering the question, what's the most likely diagnosis? Well, we know it's muscle weakness, so it's what the word means. Myasthenia. My means muscle. A without. Stenos is the Greek word for strength. Muscles without strength. But which muscles? You're going to look for double vision, decreased chewing, double vision because the extraocular muscles get weak, and those muscles get weak particularly towards the end of the day, and difficulty chewing because it's a repetitive muscular exercise. The strongest muscle in the male body is the masseter. The second strongest in a woman. The single strongest is the uterus. But the strongest in the male body, and the one most commonly used, is simply chewing. Weakness of the limb muscles is definitely at the end of the day because what ends up happening is that you have a limited number of receptors and you simply don't have enough stimulation to create the strength you need. Ptosis is your eyelids are drooping because the muscles get weak. The levator palpebrae superioris muscle gets weak, especially towards the end of the day. And the key feature is that the more you exercise, the weaker you get. But this doesn't affect the pupils, interestingly enough. Now, extraocular muscles and the muscles of mastication are virtually the only two muscular activities that is done by everybody. Reading these words right now requires muscular exertion on the part of your eyeballs. So if you start seeing two words here, or fuzziness, it could be myasthenia gravis. The best initial test for myasthenia gravis is acetylcholine receptor antibodies. That's the fundamental defect here. The most common wrong answer is edrophonium testing. Acetylcholine receptor antibodies can be done more easily and have more sensitivity and specificity. They are definitely a better answer than edrophonium testing. Edrophonium is a short-acting inhibitor of acetylcholine esterase. Temporarily, it bumps up acetylcholine levels, and there should be a very clear improvement in motor function, but it only lasts a few minutes. Now, this is something where you say, hey, hold your arms out, and we'll see how long you can hold them out in front of you before and after edrophonium. But this is a test that's fraught with inaccuracies, these types of functional tests. Acetylcholine receptor antibodies is a much better choice and the right answer on your test. Receptor antibodies is not as accurate as electromyography, particularly single fiber electromyography. Put a needle into that muscle and see what happens to the muscular contraction with repetitive stimulation. Now, when the question says what imaging should be done, the imaging is always chest something, chest X-ray, chest CT, chest MRI. We're looking for thymoma, we're looking for thymic hyperplasia, and that is especially important because when the initial set of drugs don't work, we're going to take out that thymus. Thymectomy is to myasthenia as splenectomy is to ITP, immune thrombocytopenic purpura. Your initial therapy doesn't work, get rid of the organ controlling the immune response. In this case, the thymus. The best initial therapy from myasthenia gravis is pyridostigmine or neostigmine. Neostigmine and pyridostigmine, which are simply longer-acting versions of edrophonium. Now, the problem is that these drugs don't stop progression of the disease. They just don't. They don't stop progression of the disease because the antibodies are still ripping up your receptors, but they are the initial therapy. Thymectomy and myasthenia, just remember, this is a big deal if you have myasthenia and you're not controlled by these drugs. Getting rid of the thymus, thymectomy and myasthenia is like a splenectomy and ITP, and it's going to improve that recurrent hard-to-control disease, I promise. It works in 60 to 80%. So when do I answer thymectomy? If medications don't control the disease, and what I mean by medications is pyridostigmine, neostigmine, the most appropriate next step in management is thymectomy if they're under the age of 60 or 70. If they're over age 60, you can't teach an old T-cell new tricks, and you gotta find a different way to control those T-cells. So therefore, if they're too old for thymectomy, you use steroids while waiting for azathioprine, cyclophosphamide, or mycophenolate, which are used to get the patient off the steroids. And then you can lower the dose of prednisone. And that's what azathioprine and mycophenolate are used for in a lot of things. Immunosuppressives, and later you get them off the steroids. And this is a person who's life-threateningly ill, severe overwhelming disease, profound weakness, respiratory involvement, and just like Guillain-Barré, intravenous immunoglobulins or plasmapheresis, no combinations. Combo, no help.